welcome to the Health Revolution. I'm your host, Adriana Morrison, and I am so thrilled that you are here today. Remember, our show is all about engaging conversation, elevating health and wellness, and empowering transformation. And as we get rolling, don't forget to check out the show notes at the bottom of the screen, because you're going to want to have that reference information for all of the colossal nuggets we are going to have today. And I am thrilled and excited about my guest today. She is the epitome of a rock star when it comes to those of us in perimenopause and the menopause journey and redefining what it means to step into this new chapter of our lives as women. She is none other than Dr. Mary Claire Haver. She is the author of the book, The Galveston Diet. And let me tell you, this is a national bestseller. And this book is going strong, and it has been going strong for the last 8 months or so. And she is a force to be reckoned with. So this is a very important conversation for all of us to have. So without further ado, Dr. Mary Claire, welcome to the show.
Thanks for having me.
I appreciate you being here. So tell us, of course, tell us a little bit about your journey and all the different places that you represent, the roles that you are playing today.
So I began this journey, probably harken back to 2014, 2015. I was perimenopausal, more than likely, but I had been on birth control pills for contraception and treatment of a condition that I had for years. So I kind of my perimenopause was pretty much treated. And I was in my late 40s. My oldest brother at the time, my very oldest brother, died when I was 9 from leukemia. It's all part of my story. And then my next brother was very ill with hepatitis and HIV. And Bob, we got the call that he had had a stroke and I had to rush home. And at the same time, I had stopped birth control pills, and after discussion with my practitioner to see kind of where I was at in my menopause state. Was I fully menopausal? Was I, did I have a few more years left? And in my rush to go and take care of my brother, I forgot my own health care. I just went home. My sister and I did his end of life care, and he ended up passing away, within a week or so. And then I went into a really tough time of depression and questioning myself and our relationship, and was having really hard time sleeping, waking up multiple times in the night. I was gaining, weight in strange places that I had never gained weight before. And I just really attributed everything to grief. And certainly that was a part of it. But I was gaslighting myself from my own menopause symptoms. I mean, I was having hot flashes. I was having disrupted sleep. I was having brain fog and anxiety. And so once the depression and, grief cloud was lifting and I was feeling like, okay, I can get on with my life, the other symptoms remained. And I thought, oh my gosh, I'm in menopause. Like, I haven't had a period in 6 months, and I just totally forgot. So at that point, I was always one of those girlies who thought that I would have this like magical menopause, that I wouldn't have any symptoms, and because I was so healthy and I was exercising and trying to eat right and everything. And here I was with this inner tube around my waist, not sleeping, acne, losing my hair, like all of these things were happening. And I thought, oh my God, I'm gonna have to be one of those poor people who has to take hormone therapy. And started HRT, got, but the weight it was still struggling with the abdominal fat. So for the Galveston Diet, my patients, so I had worked in a small community and I was aging with my patients. We were all kind of in the same phase of life. We had babies together, and then we're gaining weight together, and we're all having symptoms together. And we're all counting calories, and we were all working out together, and it just kind of stopped working. We were healthy, but we couldn't figure out what this abdominal weight gain was. So I called up the PhD nutritionist at the university I was employed at. I was like, what is going on in menopause? Everyone's complaining of this. I can't beat it no matter how many times I go to the gym, no matter how much I restrict my calories. And they're like, well, there's a lot to do with inflammation. Menopause seems to have a connection, but we don't have a lot of research in this area. So they just threw a bunch of medical research articles about inflammation, weight gain, visceral fat. I'd never even heard of the term visceral fat before. I could feel it, but I didn't understand the medical consequences of it. So through reading all of these research articles, I started there's a lot of great information here on fasting, not so much for weight loss, but more for lowering inflammation. I realized that I was inflamed. The headaches, the joint pain, the loss of sleep, was significantly contributing to this, and what could I do outside of hormone therapy, because that's not for everyone, to help with this. And so then I started looking at Mediterranean diet and some of the anti-inflammatory nutrition principles, and then finally started looking at macro and micronutrients. Went back to school at Tulane and got certified in culinary medicine because this became my quest, and decided I made a prescriptive little program for my patients. And it didn't have a name. It was not the Galveston Diet. It was just, here you go. I made this up. See if it works and let me know. And I was making copies at the local Office Depot. My patients started sharing it with their girlfriends. It was working great for me. My girlfriends wanted to know what I was doing. And then I started talking about it on social media. And that's when it really kind of exploded. And so I started running these test groups in Facebook, private Facebook groups. And I would ask for volunteers from my little followers. Hey, who wants to try my program? Me. I put 100 of them in a group every month, and I would coach them through basically what the book is about. I made little slides. Everything was homemade, just me having fun, doing something on the side. And through a year of that, about 1,500 people I took through the program, they gave me so much feedback on what was easy to understand, what I needed to explain better. This was too technical. We need some meal plans. Here's some recipe ideas. And then it just all kind of came together. And so finally it was getting so big on social, someone, a physician entrepreneur friend was like, you should do something with this. I was like, no, I have a good job, You should, you're reaching so many people, it's really starting to resonate. You should really turn this into a book or a program or something. So I tried an ebook, and that was a disaster. That was not the right platform for me, because it really took me kind of in video explaining. And so then someone suggested a online course, and I go, what's that? And they said, oh, there's these courses you can take online, you video everything, and you can make slides, and it's you talking. And I thought, well, that might work. So I launched the video course and I named it Galveston Diet after the place where I was living and where my kids were growing up. And just said, well, we'll see what happens. And within 6 months, we had done over 6 figures of, and people were sharing it, and it was growing on social media. Then kind of what started evolving is the more I'm talking about nutrition and menopause, inflammation and menopause, weight gain and menopause, more menopause questions were coming in, and the conversation got bigger and bigger and bigger, and I kept reading. And I thought, we're not serving the menopause population in OB-GYN as well as they could be served. There are so many gaps in my own knowledge, and I was a straight A student. I blew the top off the boards. Like I thought when I graduated from my training program that I knew everything about menopause, and I knew this much. And It really sadly took me going through it and realizing that there's a huge vacuum here, and to kind of develop kind of where we are today with Galveston Diet and now Menopause Life.
Wow. So. And honestly, your journey is incredible, because it's very telling where we are. And how have you seen the medical community? What's been the input, even from when you were becoming a board certified OB-GYN, and then just all the points along the way? What did you notice about the community, and then just your revelations with menopause?
So this is a big tell, and this is something I look back with shame, but I have tried to grow and learn from it. So it's a story I tell freely, but it is really one of the saddest things that I can think of how we treat women in medicine. And there was a great story in the New Yorker, I don't know if you saw it, where they talked about 2 different patients. One was a woman of color and one was a white man. And they came in with the exact same complaints and the exact same diagnosis. And the picture was a male physician with a stethoscope on her head and a stethoscope on his heart. And how often so many of our symptoms as women get attributed to psychological reasons rather than a true physical cause. And part of where menopause has been left behind is that only we go through it as women. And sometimes men just can't relate. It doesn't, you're just getting older, this is a part of aging, rather than this dramatic change in our health span and lifespan. If women did not go through menopause, if we were like men and had some decrease in our sex hormones, but really they can reproduce till they die, right? And so if that happened to us, it would dramatically change our lifespan and health span. from the diseases we would eventually die from. Our risk of cardiovascular disease dramatically increases after menopause. Our risk of osteoporosis, which we've known, but our risk of mental health disorders, our risk of autoimmune disease, all of that changes as we age. So here I was, a resident in the clinics, and we had this kind of gynecology clinic that was a catch-all for everything, discharges, whatever complaints. And there was a code name that we used for a woman who came in and maybe she wasn't sleeping well, or she had some aches and pains, and she was gaining some weight and her hair was changing, and it was called a WW, which is a whining woman. And if she was Caucasian, it was a WWW, a whiny white woman. And so you'd have your chart and be like, you pick it up and because that was what we were, and it didn't go in the chart. We never would write that in the chart, and that was just like lore that was handed down. And I have to catch myself to this day when I start listening to a list of complaints to not automatically assume that it's stress or aging or anything else. Like, I need to find the root cause of this for her and help her, and certainly those things can contribute, but we don't do that with male patients.
Where do you think the deficit is in, say, the medical community and say women just reaching out, going, I don't even know where to start? Where is the gap of all of that?
I think it's a systemic issue. So
Okay.
There's not one thing. I think it is how we view women's medical issues, and this is, if there's a great book called The Unwell Woman, and it talks about the history of medicine from a female health perspective. One of the things is that in many health conditions, we've always just, human beings were considered to be the same. And anytime that a woman typically presented different than a man did, like her set of symptoms, it's considered atypical. Like, what a male goes through is the standard as far as his symptoms of a heart attack is a really good example. A woman doesn't have chest pain, shortness of breath necessarily. She may have jaw pain or something radiating or indigestion or whatever, and that's atypical chest pain. Whereas it's how a woman usually presents. And so that has been taught since the dawn of time. If you look at, as far back as, Socrates, that, the wandering womb and humors and, anything to do with our gynecologic issues was just shrouded in mystery and related to basically the word hysterical. Hysterectomy is from the womb.
That's true.
Hysterical comes from the Greek, the Latin root for the word uterus. That's why we have a hysterectomy.
Yeah, that's true.
And even, in 2023, physicians today are recommending hysterectomies for menopause. And it just,
That's wild. I never knew that before. I never knew that this was something that's
outside of the menopausal women's surgical needs, OB-GYN training programs, and I was a program director for 15 years, have very little education around what can be done for them. But fortunately, menopause.org has grown and has wonderful resources available, but it's outside of the usual OB-GYN curriculum.
That's true. And for the viewers, menopause.org is the North American Menopause Society's official website. And so that's a powerful resource for women and even men who are supporting women as well.
Exactly.
What have you noticed in terms of debunking myths about perimenopause and menopause? How does someone who even a woman that doesn't understand yet the chronological path that many women take, where does one begin to study like what's happening to the body and all of that? What will help us?
One, it's to understand that there are estrogen receptors in every organ system of our body. And it's not just hot flashes and night sweats. So that's like myth number one, that it's just hot flashes and they'll go away, and they will go away eventually. And that it can start as early as your early 30s. So the average age of menopause is 51 in the US, but normal is still 45 to 55. And menopause is defined as one day in your life. And it is 1 year after your last menstrual period, if you still have a uterus. So it represents the end of your ovaries, sex hormone production forever. Basically, our ovaries, the glands we're born with at birth, we're born with all of our eggs. They start developing when we're embryonic, and they max at 5 months of pregnancy, okay? And so if you think about it, your grandmother had your genetic tissue carried inside of her when your mother was in the womb.
That is wild.
Yeah.
That is so, I've never thought of that before.
Whereas a man in the testes, they make their genetic, their sperm fresh every day. Their gonads,
Right.
and their germ cells is the technical term. So, whereas we're born with ours, so we have a stock supply, and they age and deteriorate from birth all the way through. They start ovulating at puberty. We lose 1 a month. At least 1 a month, probably more. And then when we're about age 30, we're down to about 10% of our egg supply. And at age 40, typically we're down to about 3%.
Okay, I never knew those stats.
So when you think about the genetic variation and the environmental causes of earlier, surgery, radiation, different things, in the environment that can make us go through menopause earlier. So 45 to 55 is still normal, and menopause, like when your body's recognizing like, hey, we don't have as much estrogen as we used to, this monthly ebb and flow, this symphony that we go through every month is starting to, things are starting.
You say symphony, I feel like it's more like noise.
Start 7 to 10 years before your period stops. So a 35-year-old woman absolutely can start showing signs of estrogen depletion from perimenopause. And that's, being told you're too young. I mean, that is an absolute myth.
So the language that's being used in women having these conversations with their healthcare providers, what have you noticed in terms of what are you hearing from your patients and other women that is the breakdown of communication?
So there are certain physicians that are just did not receive the proper education and training or any, and are getting into the hormone, world, and just categorically dismissing even a conversation. This is part of aging, get over it, move on. And not recognizing the suffering that could be alleviated or the improvement of our overall health. And so that's one issue. 2, there's a lot of bias that people are, you should do everything natural, you should, and I think it's because men don't have something similar. The process of menopause is natural, but it doesn't mean that it can't be pathologic. There are a lot of things that are natural that are very pathologic, or that we seek help for. Presbyopia. I can't see very well without my glasses, but no one looks at me. And a famous example is erectile dysfunction. That is a normal part of aging. And no one gets upset, other than maybe his wife, about, the use of medications to help with that. And so it's like a double standard, and we're on the, the bad end of it.
So in terms of the training, so you mentioned that the training is just not quite where it needs to be for physicians. Right. What's been the conversation like amongst colleagues?
So a lot of us are, especially, my colleagues and I, we were mostly female in my residency program. So there were 8 of us. Well, actually, they're almost all female now, but we were probably, I think we had 5 and 3 by the time we graduated, 5 women, 3 men. And we're all still friends, several of us. And so, the texting back and forth of, wow, we need to learn more, we need to know more, we need to be able to do more to help these women, where we just really thought, oh, well, give her HRT if she's dying, and because we were so worried about perceived risk of breast cancer, which is totally was blown out of proportion. So it turns out that hormone replacement therapy is massively helpful and safe for the vast majority of women, and so many women are being told that they're not candidates when that's just not true.
How does a woman have that conversation with her healthcare provider if that's the feedback that they've been getting, and she's been with him or her for such a long time?
Let me warn your followers that your doctor who took care of you and delivered your babies and was this awesome like resource for you for so much of your life may not be your best provider for your menopause.
Wow. That's, and we'll definitely get into that. We're going to take a quick commercial break. We'll be right back here on the Health Revolution.
Coming this spring, by popular demand, the second season show on the Tour of Love.
The E360 TV platform is saying we want the Tour of Love.
With winner of the first Global Impactor Award, Tamara Hunter, along with Emmy-winning co-host Skip Thomas.
We are going on tour, on the road. It's time. Love unites, and there is healing through connections. This is a worldwide movement, the Tour of Love.
Okay. Okay. We're back here on the Health Revolution. I'm your host, Adriana Morrison. We're spending some incredible quality time with Dr. Mary Claire Haber, board certified OB-GYN, and the author of the national bestseller, The Galveston Diet. And we were, Dr. Mary Claire, we were talking about how we were debunking myths and conversations of how they take place these days with women and then their healthcare providers. So you mentioned before about the same physician, the same provider who had delivered their child, and things are different nowadays, and that how does a woman transition from say a provider who was helping her in a previous chapter,
Right.
and now things are different and we got to revisit the landscape?
I wrote an entire blog about this, and I have resources, and we can put in a link
Yes.
of how to advocate for yourself in menopause and how to have a conversation around HRT, because your healthcare provider may not be informed. And so I have linked the menopause.org guidelines. I have the ACOG, the American College of OB-GYN guidelines, and then I have the article from the American Heart Association, which debunked, and then a couple of articles that talked about debunking the cancer, myths. And so that has, the feedback I've gotten from providing that resource to my followers has been tremendous. But say you don't even know, I would always call ahead before you waste your time, and unless it's someone you have a great relationship with, go on in and ask, if you happen to be in there for something else, like, what's your stance on hormone replacement therapy? Do you really treat menopausal patients? And they'll usually tell you right up front, or ask to speak to the head nurse, and she'll tell you. And so what do you do if they say no? You're just categorically denied, no conversation had, I don't believe in it. Well, it's not Santa Claus, by the way. So there are other resources. So the menopause.org has a list of certified providers on their website. Not all of them are fabulous, but it is a place to start. You're more than likely able to find someone. We have a list on our website as well that were recommended by my followers on galvestondiet.com, and they wrote testimonials, so you can maybe see if there's someone in your area. If you're in Houston, you can come see me. or one of my providers. And also, there's some now great telemedicine options out there available, companies built to serve menopausal women specifically.
What's been the dialogue, or how has the dialogue changed as you're talking with others within the medical community, and more and more people are getting to know your trailblazing efforts to really change the landscape of how we approach menopause as a society?
So it's been neat. Most of the feedback I've gotten from fellow providers, and it's mostly through DMs from social media, have been very, very positive. Like, thank you so much. I'm learning from you. I've changed my practice patterns because of you. I read the articles you recommended. I'm getting certified from NAMS, North American Menopause Society. Like, I see a need here. If there's any negative, they're just talking amongst themselves and keeping it. I'm sure there's who she thinks she is. She just wants to be a TikTok star, but really my focus on social media is simply to educate so that you make decisions for your own healthcare based on facts and not fear.
And I'll tell you, I love what you're doing on social media, because I think that you're using the platform just to have some really truly relevant conversations and just putting that input out there. That's how I first discovered you, and I thought, wow, this is a woman who is really resilient in helping the rest of us just live better as we're moving forward. So many flowers to you for doing that. One of the things I wanted to talk about was in terms of going through perimenopause and menopause and the sometimes dicey conversation of HRT. What is the best way for a woman to approach hormonal replacement therapy, and what can help her decide if it's best for her based on her history?
Sure. So when we look at any medication in medicine, your healthcare provider's job is to discuss the risks and the benefits as they relate to you and your personal health history and profile and your needs and wants. And as long as the benefits outweigh the risks, then you together make a shared decision whether or not you're going to proceed with that. And I think what's missing out of the conversation around hormone therapy in most healthcare providers' offices is the risks of not taking it. All anybody talks about is the risks of taking it, rather than what happens if I don't take HRT. Well, you're going to die sooner. You're more than likely going to have a fracture, and within that fracture, you have a 25% chance of death, within a year, okay, of a hip fracture. And you will have a dry, painful vagina and not be able to enjoy intercourse, for most of us, more than 50% of us, as we get older. You will have a higher chance of depression and anxiety. You have a higher chance of cardiovascular disease and death from cardiovascular disease if you don't start within the recommended ages. And so I am, but that is the conversation I think that is lacking in the risk-benefit profile of what happens if I don't take it, okay? Well, you're not gonna live as long. You're more likely to have heart disease. You're more likely to die earlier from heart disease. You're more likely to have a fracture and die from a fracture. All of those conversations need to be had as well.
Are there contraindicators that are within
like any medication, like Tylenol and ibuprofen? Not everyone is a candidate. And so who is actually, and I can talk about the myths here as well, the absolute contraindications to, and when we talk about hormone therapy in menopause, we're talking about estrogen plus or minus progesterone. Testosterone is a separate conversation, okay? So specifically for estrogen, if you have an estrogen-sensitive cancer that you are actively treating, you should not be on hormone replacement therapy, okay? If you have an estrogen receptor breast cancer, if you have any breast cancer within the that's been treated in the last 6 months, you should not consider it. Does that mean everyone with a history of breast cancer is not a candidate for hormone replacement therapy? No.
Okay, so that's good to know, because sometimes you hear that women
there are patients who are well recovered years out from their, they've done their chemo and their radiation, and they've had their whatever treatment, and they've been told categorically that they cannot ever take hormone replacement therapy. Estrogen does not cause breast cancer. It might feed a breast cancer, but it is not the cause. Otherwise, pregnancy, our hormone levels are as high as 5 times our normal reproductive lives, and less than 0.0001% of women get breast cancer in pregnancy. It's possible, but it's extremely rare. So you have to have breasts to get breast cancer, and estrogen might feed the cancer, but it is not the cause. So women who are on hormone replacement therapy at the time of their cancer diagnosis are diagnosed earlier and have higher, less, 20% chance less of death than a woman who was not on it at the same time. These are things we're not telling patients. So your family history of breast cancer does not rule out that you cannot have hormone replacement therapy.
Wow, okay.
So another is if you have undiagnosed vaginal bleeding, okay, any abnormal vaginal bleeding, sorry. So if you are having irregular periods, some spotting, and you haven't been evaluated for that, it's not the time to start hormone replacement therapy. Now, it may be perimenopause that is causing your cycle wonkiness, but until you figure out if it's polyps or perimenopause or whatever, you shouldn't start hormone replacement therapy until that gets worked out. If you have had a blood clot within the last 6 months, most experts are recommending, let's get that worked up, figure out why you had a blood clot, and let's wait the 6 months before we consider starting. But if you have had a blood clot more than 6 months ago, or you have a clotting disorder, or the MTHFR gene or whatever, you are still a candidate. We just do transdermal instead of oral. Oral only carries the increased risk of clotting, not the other ways of getting it in your body.
Wow, this is good clarity. What is there a window period in which a woman can take advantage of HRT? Like, say, if
you can have a hormone replacement therapy at any point of your life.
Okay.
That is still your decision. But there are windows of opportunity where you will have more benefits for cardiovascular disease and Alzheimer's and dementia than you were, and that's when you start very close to within 10 years of your menopause. So as long as you start early, so there's something called the healthy cell hypothesis, where estrogen is such a powerful anti-inflammatory hormone in multiple organ systems of our body, and it's very protective. And so it is why after menopause, our heart disease risk approaches a man's, when before we were protected. Our bone density, if you get on HRT, before you miss your estrogen, you will have strong bones for much, much, much longer. Your risk of osteoporosis will be that of a man's. And so there is a window of opportunity. Now, once heart disease has started, you have coronary artery disease, you have Alzheimer's and dementia. Those are not the times to start hormone replacement therapy, because estrogen added to those situations, it's too late. It's not protective, and it may actually be harmful.
Wow, so then what's the best approach? So the conversation to have with physicians, like say you have a perimenopausal, you have a woman, or even a woman that's entering menopause, and she wants to delve into this, but the doctor has not approached her about this.
All I can say is, once you hand them the evidence, you can go to my website, download the articles, print them out, and take them. And patients have done this, and say, tell me the reason why I can't have this, and they still fight you. You need a new doctor.
Wow.
They're not going to be on board with you.
Wow. And why do you think that is? Do you think it's because they're so that maybe that they feel that the training that they've had is certain, and that there's no other additional training?
We're all supposed to undergo continuing medical education, but unfortunately, and I'm calling them out here, the American Board of OB-GYN, who board certifies us and keeps up our certification every year, rarely has a menopause article. Rarely is putting the articles in front of the docs saying, this is important, we need to keep up with this. It's almost never. And so, again, it's a systemic issue. And if you're not trained, how can you possibly, and the way our insurance system works, there's no code in Medicare for menopause.
Never knew that.
The wellness exam for a woman after the age of 65, according to Medicare, is screening for breast and cervical cancer. Nothing else.
Oh, wow.
They're not paying for menopause care.
Wow.
Insurance companies, it's a conversation. So in my clinic, I don't accept insurance. I use insurance I let them use their insurance for their prescriptions and everything, but they will not pay me to take that hour and sit there with a patient and untangle all of her menopause story and make sure it's not hypothyroidism also, and autoimmune disease or whatever. You know, I've diagnosed lupus and lots of things in my clinic. And so, you know, do body scans, talk about nutrition. And so when we talk about menopause care, I want to be clear, it's not just hormone replacement therapy. You know, that is something that is one tool in your toolkit. So when I talk about my menopause toolkit, right? There's multiple. It's like the caboodles when we were kids. You know, if your mom was lucky enough, if you were lucky enough to get your mom to buy it for you. And so, in the most important box in that toolkit is nutrition.
Agreed.
And that is something that 98% of physicians know nothing about, and that's not their fault. You know, they have an undergrad in biology, and then they went straight to med school. And so we are taught little to nothing about nutrition. I went back to school to be able to write this book and learn this. The next important thing is exercise. So moving your body and not just burning calories. We need to stay strong. We need to build muscle. We need to hang on to our muscle. Sarcopenia is coming after us, the loss of muscle mass with age, and it accelerates in menopause. So, you know, when people come in complaining of weight gain in menopause, and I was one of them, it is more about the loss of lean mass and the gain of visceral and abdominal fat, and how that makes you so much more unhealthy. So nutrition, exercise. Then we talk about pharmacology. Hormone replacement therapy or not, or other. You know, we have other medications that might treat your hot flashes. We have other medications to keep your bones strong. We have other ways to keep your vagina healthy that don't include estrogen if you're not a candidate, but actually everyone is a candidate for vaginal estrogen. So, you know, that big conversation. And we talk about supplementation. You know, if there are gaps in her nutrition, or we think maybe turmeric might be helpful for her inflammation and joint pain, or it helps with hot flashes as well. So we talk about that. And then we talk about stress reduction, because again, we're human, we're stressed out, you know, and we need to get a handle on that, putting up boundaries, you know. It's tough. I've got aging parents. I've got a little past teenage years, girls, and I'm taking care of both sets, you know. And so that's a unique position we're in our lives, and that can cause a lot of stress. And then we talk about sleep optimization and how much that has changed as, you know, we've entered this phase of our lives, and how important it is. And so doctors are really only taught pharmacology of that toolkit.
Do you think that maybe there's an apprehensiveness because it's maybe unknown territory, that maybe it's bigger than what anyone
I think
imagined?
I can tell you from my personal learning, knowledge, experience, this is so much bigger than I ever imagined. I didn't understand what the loss of estrogen would do to a body. You know, I knew that the hot flashes, I knew the night sweats, I knew the vaginal changes, I knew the genital urinary stuff, I knew the osteoporosis. I didn't know about the Alzheimer's and dementia. I didn't know about skin changes, hair changes, nail changes, gut changes, the gut microbiome, that, you know, like how it, and then it all just puts you into this negative feedback cycle where we lose our resilience. I mean, most of my patients come to me and they were high functioning individuals. They were rocking their lives, you know. They had stress, they had problems, they had all the normal stuff, and all of a sudden, they can't handle it anymore. And nothing's changed in their environment, but their loss of estrogen.
Wow, that's incredible. I want to throw something out at you to get your take. So I had wondered about, of course, the concept that we understand, like, say, Karen, right?
Mm-hmm.
And just the
WWW.
Yes. How much of that, like, say, when the media, when there's different, when, say, someone is painted as a Karen,
Mm-hmm.
and who we perceive, like, who might fit the mold, how much of the menopause journey could be contributing to why, say, that woman is maybe having a hard time in that situation, and she's just, it was wrong place at the wrong time, or, you know, aside from extreme cases, but how much of the menopause journey might be contributing to, say her?
So I've wondered that myself when I see some of these videos, and one, it's a very high place of privilege where you can act like that in public. There are other people who don't have that opportunity to be able to get away with it. They're not getting away with it because of social media, but for every Karen on camera, there's probably 600 who someone didn't have their iPhone out when the stuff went down.
Right.
So I don't know, you know. But I've thought the same thing. Like, is she really just losing it because she is just at her wit's end right now, and this is how it's manifesting for her? and we just provided more support. If she didn't go through this blind, if she didn't wake up with all these symptoms and be gaslit and told she was crazy and it was all in her head and whatever, like this is what has happened, that this societal way that we treat an aging woman is what's manifesting. I don't know.
I had wondered about that, and I thought, it's when you see when you see situations, or maybe like in person, where when you see a woman just having a hard time, I couldn't help but wonder, is she having internally, is she just struggling and everything is just not
too much? Yeah.
Yes.
And 10 years ago, she had the exact same environment, but she was fine. She could deal with it. There are some gifts of menopause though. Like here's what I've seen in my life and what I talk to my patients about. I've learned to put up boundaries. Like I've had to prioritize myself, finally. Otherwise, I'm not gonna make it. I'm not gonna be the mother that I need, I'm not mothering my children anymore. They're 19 and 22. I'm trying to figure out this next phase of having adult children. But like, putting up boundaries with people in my life who I let drag me down, hurt me, take me to negative places. And I know that I can't do that. I can love them from afar, but I can't let them into this space that I've created with my own family. And I talk to my patients a lot about this, about how they, and kind of my give a care factor to, you know what I'm trying to say, but has kind of gone away. You see it on me. You see it, I'm living it on social media right now, where I get on video and I don't have any makeup on, I'm still in my pajamas drinking coffee, and I just feel like I need to share this with the world, of whatever menopause fact that I want to share. And so I find that that's a gift, that I can be more of who I am and prioritize myself and my needs, because if I don't, I'm not going to do well. I might be a Karen.
We're going to take a quick commercial break, and we'll be right back here on the Health Revolution.
Life is so fragile, and we're constantly reminded just how fragile life can be, especially when we or a loved one is told we have cancer. Cancer survivor myself, I can tell you, we still feel very alone in this journey.
There's a study that's been showing that patients who are socially isolated have a worse prognosis, have a worse outcome than patients who are socially interconnected.
Buddies for Life is a non-profit cancer support group for those whose life has been impacted by cancer. Humor, hope, heart, and hugs.
Humor, hope, heart, hugs, and a whole lot of love.
Share this with your friends and family and support this community in every way you can. No one should face cancer alone.
I am a chemo buddy for life.
We are a buddies network.
No one does cancer alone.
Be a buddy.
And we are all here for you as a community of love.
We are chemo buddies for life.
And if you've heard 3 words, you have cancer, for yourself or someone else, you belong with us at Chemo Buddies for Life.
Healing through connections.
We're back here on the Health Revolution. I'm your host, Adriana Morrison, spending some incredible and much needed time with Dr. Mary Claire Haver. She is the author of the book, The Galveston Diet, and definitely want to talk about her upcoming book. So let's talk about your second book.
So I'm writing a book. We've titled it The New Menopause.
Ooh.
And it is where this was more of a nutrition, lifestyle, a little primer on hormones. I kind of put my toe in the water. But the feedback we got from this book was more. I want more. What about HRT? What options do I have? Do I do these pellets? What is, which is safe? What is the actual evidence? What is this itchy head? What am I doing with my headaches? Why did this start? And I thought, I got to write another book, you know? And so it's kind of like a what to expect when you're never going to expect again. To borrow, to borrow, you know, a tongue in cheek and props to what to expect when you're expecting. So it's something that every woman could read, every partner could read, every loved one could read, but really a 35-year-old could pick up and be like, okay, I'm ready. I know what's coming. I know what could happen. I know what my options are. I understand what my risks are. And now I feel prepared to make the best decision for my health based on the facts that as far as I understand them right now.
Wow. And so, and with your book, what is the one thing, the one message that you want women to receive and continue to receive with what we're going through as we get older?
You know, in both books, this is real, this is happening, this is not your fault. You are not crazy. And, you know, understanding that, and it's the first place where women have told me they finally felt validated. You know, even in the Galveston Diet, when I just kind of touch on what could happen in menopause, that this is real, we're all going through it, and we need to start talking about it. So that, and educating our children about it, and sharing our experiences, so that, and fighting from legislative level, with your physicians, with the, you know, the boards, the medical boards, to change so that menopause is recognized as a condition, that its treatment is covered by insurance, that we're educating our healthcare providers as much as we can about it, and so that when a woman enters this phase of life, she's supported.
Wow. Now, when it comes to just the board for OB-GYN and all of that, what has how have things, what do the moving pieces look like? I'm assuming that they know what's happening with the Galveston Diet.
I've gotten some feedback and that they're paying attention.
Okay.
And I'm very, very careful on social media. I give evidence. I put articles up. You'll often, 9 times out of 10, I have the PMID number for a medical research article, or I'll have it behind me. As I'm like a green screen of the actual front copy of the article where I'm discussing the key points and how it could affect someone's health. So I think that they're realizing also menopause.org is incredible, you know, and they are such a great resource. I'm constantly referring back to them. So, you know, for your followers, using them as a resource and, you know, finding out who the certified providers are through there is really a great place to start.
I love that, and I will say that I've seen some of your content on social media, and you are spot on with the you come with the receipts, and you're showing where, you know, what the latest research is. And I think for the rest of us who are learning alongside of like what's happening, this is very vital. And I can certainly appreciate just all of the effort and energy that you're putting into this. In terms of your practice, say any of the viewers are like, wow, I really wish I can connect with her. What does that look like if someone is wanting to reach out to you, if someone is wanting to work with you, or if they say, gosh, I wish you were my OB-GYN, like how do you address that?
So you can make an appointment with our clinic, and your first visit is a whole hour, and we go through a very comprehensive medical history. Your visit includes all of your blood work, you know, whatever we find is necessary at the time. We look at the comprehensive picture: nutrition, exercise, pharmacology, you know, sleep, stress. We try to cover everything in that visit so that we are setting you up to have the healthiest next 20 to 30 years of your life. This is not a quick weight loss plan. This is helping you develop a lifestyle that you can sustain so that you can have a high quality of life, and at 70 be climbing mountains or picking up grandbabies, or, you know, and not be wheelchair bound. You know, there's no guarantees for this, but like, what do you want? I tell my patients, you know, what do you want? What's your goal? And they're like, I just don't want to be what my mom's going through right now, or my aunts, or whomever, you know. And especially in my house, that's really big. These last 10 years of my parents' lives have been really tough, and really watching that decline. I don't expect to live forever, but I really want to be as functional as possible and be able to take care of myself and think. lift, move, squat, get out of the tub, get off the toilet, and the decisions we're making right now are going to determine if that's going to happen for us or not.
Wow. So what do you have on the horizon in addition to
the new book?
Yes.
And then we are going to have a menopause retreat, and I live in Galveston, Texas, and there's a big cruise port there. So we've decided to do a really fun, quick 5-day cruise leaving January 27th. There are a few spots available still. It is filling quickly though. We have 5 menopause experts coming. One is an orthopedic surgeon, we have a dermatologist, we have an exercise, physical, personal trainer. We have 2 other menopause trained healthcare providers coming who are huge in the menopause space. And it's gonna be heart to heart, talks under the stars, a lot of lectures, just in a place for us to connect. We have 100 participants coming,
Wow.
plus all of the staff, our staff to help run it, and all the docs and the sponsors who are coming. So it's going to be amazing.
Oh my gosh, that's fantastic. So where can people find you on social media?
So Dr. Mary Claire, DrMaryClare on Instagram and TikTok, and then Dr. Mary Claire Haver and the Galveston Diet as well. So.
Okay. I do have to ask you, who do you look up to in terms of who is your heroes that you've looked up to? Who are some role models for you?
So there are several people in this space. Dr. Sharon Malone is one. She's incredibly well trained. She is with Alloy Health, one of the telemedicine companies I was talking about. Every time she opens her mouth, I just want to sit down and pop popcorn and just sit there and listen to her, because she's just so eloquent, and she's so, she's walked the walk. She was a general OB-GYN practitioner. She's incredibly well trained. She's so well versed in all things menopause. Avron Blooming and Carol Tarvis, who wrote Menopause Matters, absolutely phenomenal human beings, really took their reputations, everything on the line to write this book about walking back the WHI, the Women's Health Initiative, and really breaking down what the true risks of breast cancer are, and how so many women were being denied the opportunity for hormone therapy because of one study. Wow. And Peter Attia's done a lot of work talking, about estrogen and how important it is. I mean, he's just so huge right now in this space, so I really look up to him. My daughter, she's started med school this year. She is a nutrition science major, and talk about keep me honest when you're writing a diet book. So, she's one of the most, her integrity is unimpeachable. She just is one of the hardest workers I've ever met, and, I just can't believe God put her in my arms, 23 years ago. And, my 19-year-old is the most gregarious, loving, kind-hearted, hardworking young woman. I just am so blessed with my children. So.
Wow. What kind of advice would you share with moms who are, what are some practical things that helped you as you were navigating through your journey in menopause, that as a mom, that was helpful for you?
So I, went through menopause and the death of my brother, and it was not a good time for my family. I just I saved the best of me for my patients, because I had to function at work, and I would just completely fall apart at home. I was drinking too much. I was, I was eating horrible. I can't even say that. I would just go in the pantry and just put things in my mouth, and my kids were teenagers, so young, and they needed me so much, and I could not be there for them. So it's like, I get it, Go talk to find the right healthcare provider, get the help that you need, because you've got to be there for them. And thank God my kids have forgiven me for that time of my life. But it's something I think about quite often as I really fell apart as a human being. And that's why I fight so hard for everyone else by educating, because I didn't have that.
Wow. So I know we're running out of time, but do you have a favorite quote? And if so, could you share it with us?
Let's see. You're catching me off guard on this one. I'm like, You Are Not Broken, Kelly Casperson. So she wrote the book, You Are Not Broken. And the book for her book is about libido and sexual wellness and sexual health. But it is something that's made me think about many aspects of my life. how I've gaslit myself, how I have imposter syndrome, how I, do all those things. And at the end of it, it's like, but I am who I am.
Yes.
And I'm helping people, and the feedback I get from my followers keeps me going every day.
Wow, that's incredible. And of course, I wish we had all the time in the world to chat more, but of course we don't. But thank you so much for spending time with us today. And for those of you who are tuning into the show, it's Dr. Mary Claire Haver, and you'll see all of the show notes, the Galveston Diet, all of her upcoming information. And we appreciate you being here as part of the show. Remember, you can catch us Tuesdays and Thursdays, 10 a.m. Pacific, 1 p.m. Eastern Standard Time on the Achieve TV channel on E360 TV. So until our next episode, take care, and we'll see you soon.